I will say that early on we were still intubating patients. I don't think we were alone in that. I think that was kind of the national message that we were getting. And quite frankly, we weren't seeing the results.
This is Velocity from Vapotherm. Each episode, we join conversations among clinical peers throughout the hospital and throughout the country on topics of respiratory care. In today's episode, John Walsh engages with 3 respiratory department leaders. You will meet Shelly Brown from Arkansas, Vernon Druses from New York, and Lenny Nyangwara from Maryland. They share their experiences on how the coronavirus pandemic has impacted their hospitals and clinical practice, and they discuss treating the respiratory symptoms associated with COVID-19. As you will hear, John Walsh is Vapotherm's Area Vice President of Clinical. It's worth noting that Vapotherm high-velocity therapy is a tool for treating respiratory distress. Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speakers. Practitioners should consult the full indications for use and operating instructions before use of any products referenced here. Now, let's join John Walsh.
Welcome, everybody. My name is John Walsh. I'm the Area Vice President of Clinical with Vapotherm and the host of today's RT Leadership Roundtable discussion. Today, we're going to focus on the use of Vapotherm's high-velocity therapy for the treatment of respiratory distress as it relates to COVID-19 patients and also non-COVID-19 patients, for those of you that may be new to the therapy, just to understand the various applications of the therapy that go beyond just maybe what we initially may have thought. So on our panel today, we have 3 respiratory leaders with diverse experience using high-velocity therapy in the acute care hospital setting. Shelly Brown, who's a System Director of Respiratory Care Services at a health system in Arkansas.
We're about a 750-bed community hospital, and we have been using the high-velocity Vapotherm units for about 6 years now. I've been a therapist for about 30 years, and I'm very still get excited about using this product. So I feel that it's made a big difference in treating our patients with respiratory distress, respiratory failure in all patient populations. So
we have Vernon Druses, who's the Director of Respiratory Therapy at an academic hospital.
My name is Vernon Druses. I operate out of Brooklyn, New York. We run about a 450-bed hospital, and been in respiratory over 30 years. But we're having a good time over here.
And we have Lenny Nyangwara, Director of Respiratory Therapy, Pulmonary Rehabilitation and Neurodiagnostic Services at a regional hospital in Maryland.
I'm a Director for Respiratory Care Services in state of Maryland. Work at a hospital that has about 420 beds. We have been using the high velocity therapy for many, many years. And we apply the therapy from neonates, ED, medical floors, and our ICU. So we have been using this way before COVID, and we used it extremely well during the COVID crisis. And we'll be able to discuss more about that.
So to get this started and to kind of tee this up, obviously, as we just illustrated, you're all from different parts of the country. So let me ask first, and I'm going to start with you, Shelly. How did COVID-19 hit your area, and what was the impact on your hospital in general, or maybe even the community?
So originally, when we first had the outbreak, we were following the models that we were all seeing on the news with, how it was going to, well, first it was really hitting at the time New York. And so we were planning for surge, making sure that we had surge capacity, and we quickly stopped all of our elective procedures in our facility.
there were some furloughs in our hospital. Fortunately, respiratory care department was not part of that. And it was all about, as far as my direction that I was given, you know, making sure that we had enough ventilators, and to, you know, do you have every day it was always a different number of ventilators. Early on, we had a meeting with our critical care physicians, and kind of the do's and don'ts, if you will, of patients that would potentially be positive. And a couple things that got brought up was, you know, we don't want to put these patients on vapotherm. We don't want to put them on BiPAP. And so I quickly intervened and said, you know, I can handle the BiPAP, but I'm not quite understanding the vapotherm. And there was concern about the aerosol that would come from that. And again, a little misinformation on physicians' part. So fortunately, vapotherm had quickly put out information of what we needed to do when we use the device with patients that are in respiratory distress because of COVID. And so, you know, the procedure that you all showed was to put a procedure mask on a patient that is wearing one. And so I really got that information out to our physicians. I will say that early on we were still intubating patients. I don't think we were alone in that. I think that was kind of the national message that we were getting. Mm-hmm. And quite frankly, we weren't seeing the results that you know, a lot of us were seeing in the country with patients not we're not able to ventilate and maintain life with these patients. And so I approached one of the physicians and said, I think early on we've got to get these patients on vapotherm, and let's go that route. And mm-hmm. So for us, it's been in treating these patients with respiratory distress because of COVID, it's been very successful for us. And so the worry of the number of ventilators and having enough of those on a daily basis, I would say in a matter of about 3 weeks, it changed to making sure we had enough vapotherm.
I see. So Lenny, I'm gonna go up to you in the Mid-Atlantic area there and Upper East Coast, and you know, how did COVID hit your hospital?
Yeah, kind of the same way as Shelly has said. Initially, we were intubating pretty much everybody that came that had respiratory distress, and vapotherm and BiPAP were both not therapies that were recommended because of the fear of aerosolization of the patient's secretions. And therefore, it was at a time when vapotherm provided guidelines on how to effectively deliver the therapy without aerosolizing the virus. That is a time when we went all out, and it's funny to hear that the results of the initial patients were not really very successful when we were intubating them, and we saw success in getting our patients treated and discharged home by simply using the vapotherm high velocity therapy. When I applied for respiratory distress, and we still had a ton of patients that were in-house, not using any oxygen therapies, but mostly we relied highly on the use of vapotherm to de-escalate the respiratory distress. And I think at some point, and somebody pointed out, and I'd not even thought of it, that the number of patients we had using the vapotherm high velocity therapy was an indicative of what we would need for ICU beds as that pipeline was going, and we were trying to ensure that we had enough ICU beds. So it was a good indicator for us to know what direction we were heading, because those who were using Vapotherm were the likely ones to get intubated if the distress had gotten worse.
I see. So Vernon, you know, you're in the epicenter there of what was happening very early on. And, you know, I'm thinking about as an RT director, you know, early on in this, we're talking late February, early March, you know, with what was coming out at the time, it seemed to change significantly within just a matter of a week or two. From everything's going to be fine, we're going to beat this, it's going to be similar to, you know, the earlier SARS or MERS, it'll be a flash in the pan type thing, to we've got a national health crisis on our hands. And obviously New York City was kind of the epicenter of that. What was it like as an RT director preparing your staff in your hospital to get ready for that? What was that like?
Can I use the non-clinical term called chaos? It was amazingly chaotic. And you're talking about an institution that we were seeing on a regular basis, maybe 13 ventilated patients, and that was considered a heavy load. We went from 13 ventilated patients to 70 within 2 weeks. So that tells you how overwhelmed we were. We initially we were just totally overwhelmed. It was like a tsunami of patients came through the doors, and we started to intubate and provide high flow therapy, provide vapotherm therapy. Now, the problem with our vapotherm, we were just increasing our arsenal. So we had 3 in-house. We just got approved for, actually we gotten approved for 5, and our rep was able to set up 3. So we had 3 that we were able to put hands on. By the time we finished, we had to increase our fleet. But to say that we were overwhelmed, I myself as a director, because in that first week we lost, in the first 3 weeks we lost 7 therapists. So now I'm no longer the director. I'm now a respiratory therapist, working the floors, working the COVID unit. Not only that, working 14 hours, 7 days a week. Number one, to ensure that morale is high. And of course, number 2, to ensure that we have the correct staffing to help out, to ensure safe patient care. It was really, it was the most catastrophic event I've ever seen in my respiratory career. And I've been a therapist for over 33 years. So that's why I can't think of a better word of than chaotic.
Sure. Well, that's understandable. And, you know, I've spoken with several RT directors and even staff that were, you know, hit in the heavy spots. And to say that this will be a moment in time that will forever change them as a professional as well as a human being is an understatement. So I guess, you know, when you're looking at, and since, you know, you kind of mentioned early on that you had a few Vapotherms and you expanded the utilization as the crisis hit heavier, how did that evolution or that change, you know, because we heard from Shelly and we heard from Lenny as well that, you know, the earlier indications was not to really use any form of cannula therapy over 6 liters a minute. And then as it related to high VNI or Vapotherm specifically, how did that change in terms of the practice and the mindset of saying, oh boy, we got to try something different here? Or what was the thought process, or what pushed that in your continuum of care for COVID-19 and those experiencing respiratory distress?
You know, the big roadblock was super spreading. We didn't want to create a situation that would that would cause a super spreading of the disease. We wanted to control aerosolized therapy of all kinds, whether it was nebulizer, even aerosol mask, trach mask. And once we started to implement the negative pressure rooms, it gave us more latitude to utilize vapotherm therapy, high flow therapy, aerosol therapies, and things of that nature. The information that was coming in at the time, or the literature that was available at the time, we were very dependent on what was coming out of China. How the Chinese are managing and most of what China did coming to the end of their when they began to flatten the curve at the end. And we found from the Chinese study that non-invasive high velocity therapy or even high flow therapy really was pretty but how do you contain the aerosolization? And that was the problem. In the beginning, everybody was oddsman. Everybody, you throw a tube down, straight oddsnet, volume control. You were hitting peeps of 25, 30, 35 centimeters of peak. And these patients were doing horrible. Those patients that were able to, or those few patients that we had, and I could speak of a specific patient, and then I'll stop. We had one patient that was already in a negative room, a negative pressure room. She was in for a droplet precaution that was non-COVID related, but then we found out that she was a COVID positive patient. And I immediately put her on, at this time we had overwhelmed our vapotherm therapy, and I had to put her on regular high flow therapy. And she did well. So we saw the benefit of high flow therapy, but the fact is we still have our staff to protect. How do we protect our staff? How do we protect the hospital environment from super spreading? And that kept us on the ventilator. It kept us going to a closed system in order to maintain these patients.
I see. So Lenny,
Yeah.
For you, what was this transition like for you?
Really, for us, the decision to go to the use of vapotherm high velocity therapy was related to being able to protect the environment, because that was the fear that we were going to contaminate the environment, and anybody that was going to go into the patient's room was going to be subject to these aerosolized particles. And as soon as we were able to get that information from vapotherm that we can be able to use a surgical mask on patients and that would prevent the aerosolization, we went straight away to start using it.
And Shelly, you're in that same camp as far as having used this technology for quite some time. When you look at the transition and seeing this coming down the pike, you're watching this kind of close in on you from both coasts and even from the Gulf Coast in terms of how this was spreading. What was your transition and what was your discussions like when you decided, hey, we got to look outside the box of what's currently being recommended initially?
So, in some of the meetings that I was going to with other disciplines, including nursing, physicians, several disciplines at the table, one thing that just really stood out to me is that we were a little bit flying by the seat of our pants. And what I mean by that is I felt like no one could really explain why intubation was where we needed to go quickly. And in my mind, the only reasoning that I could put and reading about, what other facilities, what everybody's doing and what even they did in other countries, I kind of had thought in my mind that we were doing that as a basis of protecting the environment rather than, in my opinion, doing what was best for that patient. And so I made a comment in a meeting among my, colleagues, and I said, look, guys, we've treated tuberculosis. That's very contagious. And I really want to step back and say, let's treat this as if it's any other respiratory disease that we have this failure going on with. And let's go back to what we would normally do. Now, BiPAP, I'm not going to argue to try to put patients on BiPAP, but that's no different than any other day. But the other thing was that I did a lot of kind of reading on my own. And one of the things that stood out to me from what I was reading in some of the preliminary studies was that this virus was acting very much like carbon monoxide poisoning. And that the biggest difficulty was not with ventilating, but rather oxygenation. And so in my mindset then became, okay, if we treat carbon monoxide with, everybody knows the treatment is 100%, however long it takes to get that patient turned around. And so I decided that I felt like that may be the route that we need to go with these patients. And so we kind of went into the strategy as these patients, their needs started getting greater with oxygen. Let's say we hit 4 to 5 liters of a regular nasal cannula, then let's automatically switch over to the high velocity and go that route. And the results that we've seen have been phenomenal. And unfortunately, I've got a story where I've got 2 patients, almost exact presentation, where they came in through the emergency department. Both were placed on nasal cannulas and moved out to the floor. Unfortunately, a lot of times when patients come from the ED to the floor, respiratory care is not always in the know. So these patients may be put out there on oxygen. And then if their needs get greater, the nurses have the ability to go ahead and put them on a Venturi mask. And so on one patient, that's exactly what happened. And unfortunately, that patient stayed on that Venturi mask for several days. Now, another patient, same presentation, went to the floor. And when his needs got to 4 liters, and we were aware of this patient, when this patient's needs got to 4 liters, and we felt like we couldn't oxygenate, that patient got switched to the high velocity. And so those 2 patients ultimately both ended up, the patient on the Venturi mask, when we realized what was going on there, we quickly got him to Vapotherm. Both patients we have put on max settings of 100% 40 liters. And what we've seen is those patients, they may be on those for several days, but they do not complain of being short of breath. Some are able to ambulate in their room. They are going to ICU because we do have a policy if a patient's FiO2 requirements are greater than 80%, then they go to the ICU. But we've seen that with these patients that we're having just tremendous success. The one patient that started out on Vapotherm earlier was able to wean earlier on his Vapotherm. The other patient, it's taken longer. And so I think the big lesson learned is when the oxygenation needs, to me, it's more about an oxygenation issue when we see these patients in respiratory distress that have the COVID, that it's more of an oxygenation issue most of the time. And that if we get proactive with getting the high velocity put on these patients, we're having good success. So the transition for me literally was saying, okay, let's put aside contamination of the environment and let's go back to treating the patient. And then also it was very eye-opening for me to read the articles with the, the comparisons to carbon monoxide poisoning.
So Vernon, let me go back to you real quick. And can you walk us through the care continuum of a patient, briefly step by step on the therapy? So, the patient comes in the ER, they're a COVID suspect or they're COVID positive. Are you taking in considerations? Can you walk us through like what area of the hospital they would go to? Are you doing anything special like proning? What are some of the things you're looking for in those patients?
Okay. We actually resectioned our emergency room. I imagine that a lot of hospitals did the same thing. So we created COVID sections of the emergency room, and these sections were outfitted with negative pressure devices to create a negative pressure environment. We added doors, plexiglass doors, to keep, the negative pressure in that area. So most of these patients would be cohorted in that area. So when the therapist go down to see this patient, he or she already knew to gown up, mask up, and was prepared ahead of time. But just like Shelly said earlier, initially we had no idea who was coming through the door with what. After that, it was about observation. A lot of it was observational. We had a ton of intubations, so it was hard to count very much, or even justify who, because in the initial surge, these patients went from 90 to like 80, sitting and looking you in the face. I should say like 95. It went from a 95 saturation down to like an 80 saturation. And they're talking. They look fine. But there's this like steep dip in their pulse oximetry. At that point, we started, the team would intubate, or we would try them initially on our vapotherm therapy, and we got good results. We got very good results with the vapotherm. We even did some proning with our vapotherm. We did proning with high flow. Like I told you, we were very, our resources were very limited at the time. We tried initially to keep that patient as long as we can off the ventilator. When we ran out of resources, though, and unfortunately, I agree with what Shelly said. I believe it became more of an environmental decision than an actual patient care decision. A lot of therapists became very upset behind that because we had patients that looked like they could fly on high velocity. They were doing well, but ended up being intubated due to some form of change, or I just believe to control the aerosolization of any droplet particles. But that was basically our routine. Our routine was, non-rebreather, some form of either high velocity or high flow therapy, and then from high flow therapy to proning. We were even proning patients on non-rebreather because, and this was coming more to the end, because we wanted to really avoid intubation. So we proned as many as we can, and then eventually it became intubation and subjugation to some form of COVID unit. Unfortunately, these patients stayed forever on the ventilator. They stayed like, we had patients that stayed almost I would like to say 50 days on the ventilator. We actually had one come off that stayed 30 days. So it varied from patient to patient.
Certainly. And I think even myself locally, I've seen patients that, were on it for 40 days, 35 days, 50 days. And when you think about the typical standard or what we, for us, the norm, that's just unfathomable that a patient would be on for that long and take up a bed that long. And I think that's where a lot of the concern and flattening the curve and a lot of the discussions around that played a part. So Lenny, when you had the patient come in and you applied IV and I therapy to these patients, what was the clinical indication that you went by? What was the leader flows that were being started at? Kind of the settings. Vernon talked a little bit about proning. Was there anything special that you did with these patients? So if you could walk us through like the clinical presentation that said, oh, I got to put this patient on IV and I, to then kind of the settings and starting leader flows and whatnot you would start at. And then if you would consider proning, when did proning become a place in that continuum of care?
Yeah. So I'll talk about first like the initial settings for most patients here. We tend to start high and then titrate them down, but sometimes we have physicians that don't like to start high and they just give us settings. And then from the initial settings, we can either titrate up or titrate down. Clinical indications would be shortness of breath or desaturation for most of the COVID patients. And our patients were placed in COVID units also. And because we actually have our organization has a large physical therapy presence in the community for that is outpatient. And those physical therapists from the outpatient settings were deployed to the hospital, and we created prone teams. There was no respiratory therapists in the prone teams, but these teams went around and basically proned, I would say the majority of our COVID patients, both in ICU and outside of the ICU. And in the later days, we saw that the improvement for those patients who were not intubated and using the high velocity therapy with proning helped them actually get better sooner and go home. I just gonna touch a little bit on our fleet of high velocity devices. We had about 40, I believe, on hand at the beginning. And when we realized we were using quite a lot of them, we reached out and purchased an additional 20. And that gave us the ability to pretty much, if patient walked in, they were short of breath or they were having desaturation, that was our baseline oxygen therapy device. And with the ability to deliver that high flow or high velocity therapy with oxygenation, we were able to limit the number of patients that ended up being on the vent. And we saw that really at the point where the concern was, are we going to have enough vents to care for the patients, to the point where we were comfortable enough that if we had enough high velocity devices, then we were able to care for these patients out of the ICU and really eliminated the need for that ICU bed.
Okay, perfect. So I guess, one thing, you still intubated patients, right? You still had patients that needed to be intubated?
Yeah.
So I guess my next question is for those that did see an influx of patients being placed and intubated, put on the vent, were you using this technology for post-extubation at all?
Yes. I would say yes. First, that would be a very soft yes. because what happened is most of our patients that went on the vent had predominantly two paths. One was to tracheostomy and sorry to say this, death. We had a small number of patients that we extubated to high flow therapy, which is actually pretty much our standard here. We extubate patients and we place them on high velocity therapy post extubation. That has worked for us for a long time, and it's a common practice. But we had a very small number of patients that really got extubated and went on conventional or high velocity therapy because of the trajectory that they took once they got intubated. So really, the bulk of our patients were not on vents. At the peak, we had, I think, 42 patients on the vent. As Vernon stated, he started with on a regular number of about 15. We were about that much from 15, and at some point we were in the mid 40s. That was the peak. But then at the time we were peaking, we had the bulk of our patients using their high velocity therapy.
Wow. So Vernon, I'll go back to you. Obviously, you know, you mentioned earlier your ventilator population went up significantly in a short amount of time. So as Lenny alluded to, unfortunately, the early numbers indicated that those that were intubated had a fairly high mortality rate, but I'm assuming that you did have a lot of success after post-extubation. Were you implementing this technology at all post-extubation, and what did that look like if you did?
Yeah, I would like to say that post-extubation, we implemented a lot of high velocity therapy. Actually, it became the go-to for our patients to maintain them and avoid BiPAP, avoid non-invasive ventilation. And it was probably the most tolerable. We had great patient compliance with high velocity. They found it very comfortable, and that also helped in keeping these patients from being reintubated. It helped in their comfort. It helped with their state of well-being, because now they felt that they were. I believe the mental has a lot to do with how we heal. And if a patient feels comfortable and feels in control of their therapy to some degree, that also helps with the healing process. So it did help us to stave off reintubations. But like I said, we were limited in our capacity or limited in our resources until like say, I would like to say in April. In April, we started to get reinforcement. And at that time, we were able to really address these patients in a very more academic as well as clinical manner.
Shelly, how about you? In your post-extubation experience, were you implementing high VNI technology on your patients?
For sure. In patients that ended up being trached prior to coming off the ventilator, it's just a standard protocol, regardless of their oxygen needs, that those patients are automatically placed on vapotherm, because we'd already proven success with trachs in the use of the vapotherm. And so, yeah, that was definitely our standard practice, still is. We're just now, to be honest with you guys, we're just now starting to see a little bit of a surge in our hospital. We had maintained an average of, I'd say, 12 to 14, 15 patients a day in our hospital. Now we're up around 20 per day. Fortunately, though, what's different is that the number of ICU patients is much lower than the number of patients out on the med surg. So there's a little bit of difference on that perspective. And I think we can accredit a lot of that to the high velocity. And then some patients come in and just they don't have the horrible comorbidities. I think that's played a part in some of their outcomes as well, as how, you know, if they're diabetic, how bad is their diabetes uncontrolled versus one that may have a little more control. But definitely, yeah, anytime, it's kind of like Lenny was saying, it's our standard to place patients on the vapotherm post-extubation anytime that their oxygen needs are, you know, at a level that we can't do a nasal cannula.
So thank you all three for joining today. And, you know, I do truly appreciate your time.